Hello, everybody. I'm so glad to be there with you. I'm Dr. Emna ALLOUCHE and I am from Tunisia. We'll talk about iron deficiency and heart failure. As you know, heart failure management is very challenging and beyond all pharmacological treatment and device treatment, we have to correct and treat all patients' comorbidities such as iron deficiency, which is one of the most prevalent comorbidities in heart failure and one of the most easy to treat. Iron deficiency is very prevalent in heart failure patients, and it's found about almost 50% of heart failure patients. Iron is very important. It acts as a catalyst for important biochemical reactions. It is a component of hemoglobin and myoglobin. It plays a key role in erythropoiesis and it's a key component of mitochondria. Iron cycle is complex and the daily average intake of iron is about 10 to 20 milligrams. 1 to 2 milligrams are absorbed in the duodenum. There is no pathway for iron excretion. However, we lose daily 1 to 2 milligrams through skin desquamation and bleeding. Iron metabolism is very complex and it's regulated via hepcidin, which is a peptide secreted by the liver. Mechanisms leading to iron deficiency are multiple and complex, associating negative systemic iron balance and iron sequestration from chronic inflammation. This negative balance leads to a reduced iron stores, and inflammation via hepcidin leads to a reduced iron mobilization. In this recent analysis, iron deficiency seems to be a combination of uh, reduced iron uptake, an impaired iron storage, and iron loss. Female sex was an independent predictor of iron deficiency. Facing this issue, European Society of Cardiology strongly recommend to look for iron deficiency in every patient with heart failure. To do this, we have to forget about serum iron and we have to use ferritin and transferrin saturation. These two parameters define two types of iron deficiency. Absolute iron deficiency, which is in which ferritin is under 100 and transferrin saturation under 20%. And functional iron deficiency, in which ferritin is between 100 and 299 and transferrin saturation is under 20%. Iron deficiency has several consequences. It causes anemia, of course, and structural cardiac abnormalities. In fact, iron deficiency impairs contractility of human cardiomyocytes through decreased mitochondrial function. It also impacts badly the response to CRT therapy and left ventricular remodeling after cardiac resynchronization therapy. Iron deficiency is the cause of an impairment of exercise capacity. It is also associated with a lower quality of life in heart failure patients. Iron deficiency is a negative prognostic factor. It is stronger than anemia, and in heart failure patients, mortality increases when iron deficiency is present. So in a patient with both heart failure and iron deficiency, he will likely suffer from 13% reduced exercise capacity, and he has his quality of life reduced by 19%, and he has an increased risk of 42% to die compared to patients without iron deficiency. So we have to treat iron deficiency, but should we use oral or IV iron? We will try to find an evidence-based answer with randomized clinical trials. Iron ALLOUCHE study, a randomized trial, compared the effect of IV iron versus oral iron in heart failure patients, and it concluded that IV iron seems to be superior in improving functional capacity of heart failure patients. Then iron out, the only study with oral iron in heart failure patients with iron deficiency, and its results do not support the use of oral iron supplementation in patients with heart failure. So oral iron is not effective and in this population and should not be used. What about intravenous iron? Ferric HF study concluded that intravenous iron sucrose improved exercise capacity and symptoms in patients with chronic heart failure. AV carboxymaltose was firstly tested in FER HF, and it was shown that ferric carboxymaltose improved symptoms and exercise capacity in heart failure patients. Those results were then confirmed by in Confirm HF study, and ferric carboxymaltose resulted in sustainable improvement in functional capacity, symptoms, and quality of life. It is also associated with the risk reduction of hospitalization. Ferric carboxymaltose also in effect HF improved iron stores and had a favorable effect on peak VO2. For outcomes, meta-analysis support that ferric carboxymaltose use is associated with reduced cardiovascular death, reduced heart failure hospitalization, and cardiovascular hospitalization. To confirm this data, there are several ongoing morbidity and mortality studies with IV iron. So to overcome 1000 milligram of iron deficit in a heart failure patient, the choice of the method seems to be easy to choose. And finally, European and American guidelines recommend the use of IV iron in symptomatic heart failure patients with iron deficiency to improve functional status and quality of life. And a correction algorithm was proposed with two phases, a correction phase and a maintenance phase. As a conclusion, it is proven that iron deficiency is prevalent clinically and prognostically important irrespective of anemia. And the correction of iron deficiency with IV iron improves symptoms, quality of life, and exercise capacity. So that current guidelines recommend screening of iron status in all newly diagnosed patients with systolic heart failure and consideration of IV iron in symptomatic patients and iron deficiency. Studies have been initiated to evaluate the effect of IV iron on morbidity and mortality endpoints. After that, I think that even Popeye will switch for IV iron, and thank you for your attention.